Today I'm talking about music therapy and dementia in evidence-based researches. The first study is music therapy in moderate and severe dementia of Alzheimer's type, a case control study. The study focused to evaluate the effect of MT on BPSD. This case control study was carried out by qualified music therapists in 2 nursing homes and 2 psychiatric wards. The participants were 38 patients with moderate or severe Alzheimer's disease, assigned randomly to music therapy group and a control group. They have 6 weeks music therapy session, and after that they have 4 weeks without music therapy sessions. The study showed a significant reduction in activity disturbances in the music therapy group during a 6-week period measured with the behavior pathology in Alzheimer's disease rating scale. There was also a significant reduction in the sum of scores of activity disturbances, aggressiveness, and anxiety. Other symptoms rated by subscales of Behave 80 did not decrease significantly. 4 weeks later, the effect had mostly disappeared. The strength of this study is the design, as it is single-blinded and placebo-controlled, with comparable groups at baseline. The study included only patients with AD, other dementia being excluded. By having the same qualified music therapists for all patients and the same trained nurses as raters, possible inter-rater differences were avoided. The limitations of this study are the small size of the sample and the dropout ratio of 20%, which can be expected in this vulnerable patient group. The study did not address other types of music therapy, such as passive listening or singing. There was also no comparison between different types of music. And what we can learn from this research evidence: music therapy is a safe and effective method for treating agitation and anxiety in moderately severe and severe AD. This is in line with the result of some non-controlled studies on music therapy in dementia. Second article is Effect of Active Music Therapy and Individualized Listening to Music on Dementia, a multicenter randomized control trial. The study focused to assess the effect of music therapy and individualized listening to music on BPSDS in PWDS. In each institution, PWDS enrolled in the study were nursing home residents. In 2 institutions, some PWDS were recruited from daycare centers. Inclusion criteria were aged 65 and older. A diagnosis of dementia according to the Diagnostic and Statistical Manual, 4th edition, revised. Exclusion criteria were severe cardiovascular, pulmonary, or gastrointestinal disease, MT or LTM treatment in the previous year, and refusal to participate. Participants randomized to music therapy participated in 20 individualized 30-minute sessions, twice a week for 10 weeks. The music therapists followed the PWS rhythm and music production to create nonverbal communication. During the session, the music therapist built a relationship with the PWD by singing and using melodic and rhythmic instruments for improvisation. For the other group, during the session, the PWD listened to music from a preferred playlist without any interaction with a music therapist or formal caregiver. The results as behavior assessment did not show significant differences between groups. All groups show a reduction over time in MPI global score. In the MT group, communication and relationship between the music therapist and PWDS show a positive, albeit non-significant, trend during treatment. The strength of this study is the present study compared the effects on BPSDs of LTM in addition to SC with those of MT in addition to SC and of SC only in PWDS. Second, the objective of active MT is therefore to build a communication bridge to PWDS. In dementia, this effect may influence mental and behavioral disorders and promote new learning strategies, improving overall quality of life. In the present study, the hypothesis that the active MT approach is a better intervention than LTM to customize and modulate sonorous music stimuli on the basis of the needs and characteristic of PWS has not been proven. Also, the SC treatment differences could have influenced the results by reducing the effect of treatments. Finally, the number of sessions chosen in the design of the study may be too small for the development of a significant relationship between the PWD and the music therapies. What we can learn from this research evidence, despite the lack effect of anti-BPSDs in PWS described herein, further randomized control trials that take into account the limitation in the design of the present study are warranted. Also, a systematic qualitative and quantitative analysis of the MT sessions and of the treatment should be performed to monitor the response of each participant. In this way, the development of relationship between the PWD and the music therapy during the study may be used as a marker of potential treatment efficacy. The last study is the effect of music therapy on cognitive function in patients with dementia, a systematic review and meta-analysis. The aim of the present study was to meta-analyze the effect of music therapy on cognitive functions in patients with dementia. The study included all randomized control trials that compared MT with standard care or other non-musical types of intervention, evaluating cognitive outcomes in patients with dementia. Outcomes including global cognitive, complex attention, learning and memory, language, and perceptual motor skill. Another resource is random effects meta-analysis suggests no significant effects of MT on all outcomes. Subgroup analysis found evidence of a beneficial effect of active MT on global cognition. And the strange is, this is the first comprehension meta-analytic review focused specifically on cognitive symptoms and restricted to RCTs with music therapist involvement. The results confirms the conclusions of previous reviews, which did not find any significant improvement in global cognition. There are some weaknesses of this study. First, in the inclusion criteria, they opted for a prior definition of MT that might not be exhaustive, not taking account of the therapeutic relationship, which is of primary importance in MT setting. Second, the presence of clinical heterogeneity may have hampered the efficacy of MT intervention. In particular, the presence of samples at different stages of the disease and with different types of dementia could not be adjusted as for statistical heterogeneity. Third, in many of the present studies, cognition was not the primary outcome, and the sample size may have been not sufficiently large to detect significant changes. Fourth, they focus only on the scores obtained at primary endpoints and not on the changes occurred between the beginning and the end of intervention. And what we can learn from this research evidence? Despite the limited evidence of the present review, it is important to continue supporting MT as a complementary treatment for older adults with dementia. RCTs with larger sample size are needed to better elucidate the impact of MT on cognitive functions. And these are the references. Thank you for listening.